Welcome to part one of the lecture on CT of trauma. So, after the introduction, now we're going to start with cases. And this is the first case. And this is a CT of the first case. How do we know it's a CT? We go back and check it out, and you see it's white in the bone. So, bone white is a CT. The next thing you have to do is we have to check if you see anything that is abnormal. So, why don't we start from the periphery to the middle? If you're starting from the periphery to the middle, the first thing that maybe you can see is that as you look at the edge around the brain, there's this white rim. And that white rim is abnormal. We said that white was likely blood. So this is very likely blood. But we have to see where are we going to put this blood in. So, as I explained, when I do the trauma approach, you can do it either the way I just showed you, which from the inside to the middle, or you can do it from the middle to the outside. But I really recommend that you have a process to do this. If you don't, you're gonna very easily miss cases. One of the biggest biases that we have in radiology is satisfaction of search. That is that you're looking at a case, you see a finding, and you get so excited about that finding that you forget that you have to look at all the other things, and maybe the secondary findings that you missed are the most important for the patient, or are the true clues of what is going on with this patient. So let's start first with fluid collections that are extraaxial. And there are two types of fluid collections that we're going to talk first. One is one that has a crescentic shape, kind of like a boomerang, and another one that has a biconvex shape, which is this lentiform shape. They're very different, and their prognosis is going to be also different. And this is a very high yield topic for your training in medicine. So let's start with the one that we have here, which if you look at it carefully, it looks more like a crescentic shape than a biconvex lens. So the differential diagnosis between this is things that happen when these have this biconvex, this crescent shape, is that they're in the subdural space. The subdural space is the space between the dura mater, periphery, and deep, you get the arachnoid. And they typically can be blood products, like such as in subdural hematomas, but you can have subdural masses as well. You can have pus or subdural empyemas. And then we have to see next steps and see what are we missing. If it's a subdural mass or blood, one of the things to detect or to diagnose it is that the subdural blood, because it's deep to the dura, it follows the dural reflections, like the fox, like that tentorium, right? It will not be confined by sutures, so it can cross sutures. It does cross sutures. Another thing is that the venous bleeds can happen typically in this region because they're bridging veins. And when you shake kind of the head and the brain shakes, these bridging veins that are in the subdural space can rupture and give you these subdural hematomas. And that's why the typical case scenario that you're going to have for a subdural bleed is an elderly person who fell. They have more subdural space just because of volume loss, and the bridging veins tend to get torn, and that's why you get these acute subdural bleeds. Now, remember, they follow reflections and they're not confined to the sutures. And another thing that I'm going to leave here that I didn't include in my slide is they are not associated with fractures. Typically, they are not associated with fractures. What you need to do to see it better, if you didn't see it, is remember, you always do this blood window and you see it. And if you are really careful and you remember this case well, that not all the glitters is gold, even though this looks exactly like that. I showed you this case before. This case was actually a mass because if you do the bone window, you see this is a subdural mass that looks just like a subdural hematoma, which was a meningioma. So um, oh, that is a very important thing to remember. How do I know it's a meningioma? You'll ask, well, I did an MRI. You see the MRI. There's a T2, no CSF flare, and T1 white with contrast. And you see this thick enhancement happening here. And this is what is a meningioma. So let's take away the tricky one and just look for regular hematomas. So this is a hematoma. Actually, this is a very big one. I hope that you guys can see it. You see, it has a crescent shape. It's in the subdural space, right? Look at how big it is. It creates huge mass effects. Is it crossing the sutures? So remember the sutures of the head. It is crossing. The easiest suture here to see is the coronal suture between the frontal bone and the parietal bone. It would be there. It's crossing sutures. It has this crescent shape, and it is pushing the bone. These are all different subdurals here. So these are 6 different cases with 6 different flavors of subdurals. The top one that you see there is one where you have already layering blood products. Blood products, the blood cells tend to go to the bottom, so they could give you this gradient kind of effect. The second one, you see it in the frontal region, but it also goes to the subdural reflection. See, it's in the falx and it's in the tentorium. Remember, the tentorium is that tent between the posterior fossa and the supratentorial region. The third one is one that is kind of very heterogeneous looking. It also goes through and has a little component that goes into the falx, but this thick component is actually not blood, it's calcium. So that's why it's so important to window them. But look at all the mass effect it's doing and shifting the structures of the midline to one side. This case is so big that you have all the ventricles on the right side of the skull. There's a huge subfalcine herniation. So this is a subdural bleed acute. This one that you're seeing here is actually mostly dark. So this tends to be a chronic subdural on both sides, but if you look carefully, and this is where it's really sneaky, is that you have little streaks of hyperdensity in this chronic bleed. This is a patient that has an acute bleed on a chronic subdural. This is a super important emergency to know about because he doesn't have much space to bleed. So these patients tend to get worse so fast because they kind of had the space occupying lesion, but once you bleed again, they expand very, very fast. And they can look like this, which looks like a very small one, right? In this case, it has a calcification where we don't know it's also a meningioma. So let's go through the cases. This was the one that the gradient. This is because once the acute one happens, it starts creating a small gradient where the blood cells go to the back. It's a very frequent finding. This is the one that I showed you with the midline herniation. Very important because when the structures of the brain herniate through the dural folds, vessels get trapped as they herniate. In this case, where you have a herniation that is below the falx, we call it subfalcine, the anterior cerebral arteries get trapped and you can have frontal lobe strokes as a complication. Look at how all the ventricles are on one side, right? This one is the one that I showed you goes through the dural folds. This is just a subdural hematoma. This is another one, the one that was heterogeneous, which was a rebleed. And this one that's calcified. So we call this initially a meningioma. It actually was a subdural hematoma. So you got all of the flavors of subdural hematomas, and you got a case that was not a subdural hematoma, but it was actually a mass. So just remember they can happen. They can be bilateral, like in this case, and when you have bilateral, sometimes the herniations of the midline are not obvious because they have pressure from both sides. Um, and this one that is up here that looks just like a subdural hematoma is one of it was called a hematoma in a calcification. They thought it was that, but lo and behold, there's some periosteal reaction in the bone. You see it again, and when we did the MRI, it was another meningioma. So you sometimes you can just not be completely sure that it's a hematoma unless you look at all your windows and make sure that you're doing the right diagnosis. It's awful to just call something what it's not and tell the patient that he has an intracranial bleed when he actually has an intracranial mass. So be very careful. This is the one that I just showed you, and this is what a subdural hematoma in that same region would be. So let's do this case. What about this case? Right? You have that thing there. It's there. You have something that is superficial and it is crossing the midline. This is not a subdural just because it's crossing the midline. Remember, the subdural would follow the dural folds. This was a meningioma that also had an intraosseous component. So just be careful not to miss them. Now, let's talk now about the other lesion that is extraaxial that you have to know the difference with, which is the epidural hematoma. So the epidural hematomas are different. They have this biconvex lentiform shape. They do not cross sutures, and they do not cross sutures because the dura is attached to the sutures. So the dura creates these pockets between the dura and the calvarium that do not allow them to cross sutures. They are associated highly with skull fractures. And when they're in the temporal region, typically they're going to tear the vessels that are imprinted inside of the skull, which are the meningeal arteries, and they're going to have arterial blood, and they bleed very fast. So it can become a surgical emergency. They come in different flavors. They can be in one side, or like in this case, on both sides. I have another example. This one, you have a hematoma in the scalp. You see that the hematoma, it does not cross the sutures. You see, it stops at both sutures. And the hematoma is associated with these two fractures. So this is an acute epidural hematoma. This is a kid that came with this hematoma. We did the CT. We could not see the fracture. Is there a fracture or not? When the fractures have the same direction of the slices you're cutting, they're very hard to see. But since we can do these beautiful volume rendered images now, you can see in the volume rendered image that there's a fracture that is exactly in the same plane as we're scanning. That is there. There's an acute fracture with an acute hematoma in a kid. Now, when these hematomas happen in the posterior fossa, they really do not cross the arteries of the meningeal artery. So they tend to cross the venous sinuses, especially the transverse sinus. This is a midline fracture that you're seeing here. You have an acute epidural hematoma. Most of the bleed here is going to be venous. So the venous blood tends to ooze a little bit slower, so they do not tend to be as acutely emergent as you would have when they're in the supratentorial compartment. This is another hematoma. This is an epidural, and sometimes they can cross the midline. Once the metopic suture is closed, they can definitely cross the midline. It's not frequent, but in this case, they did. And one of the important things about these hematomas, when they create a lot of mass effect, is again that they can herniate. Herniations are not only, we have a whole class of this, but herniations are not just midline herniations, but also the brain content can try to go through the incisura. The incisura is the hole between the tent of the dura where the midbrain crosses. If the brain herniates through that, then what you're going to do is you're going to strangle the vessels that are right there, which are the posterior cerebral artery or the superior cerebellar artery. And that is what we call transtentorial herniation. And in this case, you can see that the perimesencephalic cistern is completely absent. After you treated the edema because of the herniation, look at how it started to improve the ventricular size, and you start to see again the perimesencephalic cistern. The other herniation you don't want to miss is the herniation of the cerebellar tonsils through the foramen magnum, because when that happens, you have compression on the nuclei of the midbrain, and that could be crucial for respiration centers, etc. So this was a bilateral tonsillar herniation that's improved after the patient's edema was gone. So this is the end of part one of this lecture. We reviewed epidural and subdural hematomas.